Hello, and welcome to this Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Swanson. Today's episode features coverage of new COVID-19 data from the virtual IAS COVID-19 Conference prevention. During this podcast, Professor and physician Dr. Jens Lundgren discusses important new COVID-19 data presented at the conference, including new findings on potential SARS-CoV-2 suppressive therapies, strategies for vaccination and mass testing, and interventions to prevent transmission of COVID-19 while maintaining desired outcomes in HIV care. For more information on Dr. Lundgren and for a link to additional CCO coverage of the IAS COVID-19 Conference prevention, including a downloadable slide set covering the studies in this podcast, please visit the show notes. Now, let's get started and hear what Dr. Lundgren has to say about these new data.
Thank you very much, Jennifer, and hi, everybody. I hope you have a fairly relaxing Friday. We have a number of exciting abstracts to go over from the recently held IAS conference that I'll try to review with you and discuss subsequently. The first one is on basic science using Casper technology and a study examining whether it could suppress replication of the virus. So this was evaluated using standard development time for using this technology, and the hypothesis was that the Casper technology would target and destroy RNA, and therefore potentially open a novel strategy for both prevention and treatment. And if cost-effective, could also be used for future novel RNA pathogens beyond SARS-CoV-2. The experiment was done in a traditional way by transfected cells with the gRNA for 24 to 72 hours, and then infected with the wild type of the mutant, the 614G variant of SARS-CoV-2. And then typical inhibition was examined by the TCID50, as we're using also for assessing neutralization with antibodies, for example. So this reprogrammed Cas13b gRNA target the spike transcripts, and they showed very high specificity and demonstrated more than 98% silencing efficiency in virus-free transfection models. As you can see, the depth of silencing was dose-dependent and therefore very quite impressive results, I would say. The efficacy was maintained against the mutant viruses, single nucleotide mismatches within the gRNA targeting spike transcripts, including 614G. It did not attenuate suppression of replication in the transfected model. It caused slight attenuation in mammalian cells, down to around 50% as opposed to more than 90%. And therefore, it really suggests that CRISPR technology will maintain some degree of viral suppression despite mutation-driven evolution of the virus. And therefore, certainly this study provides a molecular blueprint for antiviral therapies and something that could be developed, for example, as an inhalation treatment eventually. Next study on something different but also very important, how we should design new head-to-head trials of COVID-19 vaccines. As you know, the vaccines has been all developed in single phase 3 trials comparing the vaccine versus placebo. But given the fact that several of them obviously have shown to be effective, but have never really been compared to head-to-head, how would you actually design such a study and to really inform whether the vaccine efficacy do indeed differ, or whether the observed differences that we can see in vaccine efficacy is merely due to the fact that different people with different backgrounds was included in the different trials. Are they actually different from each other? It obviously as well becomes impossible now to do phase 3 trials where you compare against placebo, given the fact that we have several vaccines that has been proven and that obviously we're using as part of mass vaccination. So this analysis was trying to estimate the sample size required for a future 2-arm head-to-head vaccine trial based on a variety of studies that was used to qualify what would be the infection rates. And then, as you would do in head-to-head trial, examine the non-inferiority margins versus current vaccines with a reasonable and decent power of to 90% and with 80% power. As you know, in order to design a study, the sample size is typically driven by the estimated infection rates. And infection rates was drawn from various large cohorts of patients, including more than 34,000 healthcare workers that has been included in various studies. And if you combine as well the infection rates from the trials, from the 3 front-runner vaccine control arms, it was around 0.8%, whereas in the other studies using healthcare workers, it was close to 8%. And therefore, as you can see, the sample size really depends on the infection rates. And therefore, if you were studying populations similar to those in the phase 3 trials, you would need, in order to assess reduction or equivalence of symptomatic infections between 2 vaccines, you would need to include more than 80,000 people. If you want to include all PCR-confirmed infections, irrespective of whether they cause symptoms or not, it's 53,000. But given the high infection rate, if you were studying this in healthcare workers, you would be able to do studies which is less than 10,000, as you can see in the bottom table here. I believe this is important work as we need to get these head-to-head comparisons up and running, not only for the vaccines that we are currently working with, but also any future vaccines technologies. And we know that there are several hundred of those technologies on the way, and how to design those studies. And I think this analysis informed that question. Now, the next area is how to optimize vaccine strategy. As we know, there is a sparsity of vaccines, and therefore, I think many countries are debating whether a one-dose campaign can actually work. Can you stretch out the limited supplies of the vaccines by giving just one dose as opposed to maintaining the 2-dose strategy that would otherwise be recommended? And this model work was trying to examine that question. So it was a mathematical model which is combining optimization algorithms to determine which individuals should get vaccine and how many doses they should receive. It was assessed in different scenarios. We'll come back and discuss that in detail. But really the 3 strategies that the model was trying to examine is either allow the model to inform which age groups should receive either one or both doses of the vaccine. A high-risk strategy that I believe many countries is currently applying, where the oldest adults was prioritized, and then coverage extended to other groups in decreasing order as vaccine availability permits, but all groups receive 2 doses. And then finally, the pro-rata strategy, where all age groups receive 1 dose of the vaccine proportional to the population size as a strategy. So 3 relevant and hotly debated strategies were here examined. Now, this is a complicated slide, but let me bring you through the figure on the right side. So this is the model result when in a setting where the transmission is relatively low. And you can see that the single dose efficacy, SDE, was either determined to be fairly low, moderate, or high. You can see the overall vaccine efficacy was assumed to be 90%, so meaning that if you are fully vaccinated with 2 shots, you get that vaccine efficacy. But in a setting where the first dose was giving a low efficacy, a moderate, and a high is depicted on the 3 rows. And here you can see the graph, and you can see each bar is either in light blue, meaning that whatever population we're looking at here was receiving 1 dose in an optimal model-driven scenario, or whether a section of the population defined by the age was given 2 doses in darker blue. So as you can see from this and derive from this figure, with low coverage, less than 20%, the top 2, the best strategy is to vaccinate high transmission groups first. So quite surprisingly, children and young adults with either with 1 or 2 doses, depending on the single dose efficacy. Conversely, if you are operating on high coverage, but with the vaccine with a high single dose efficacy, the pro-rata strategy is best with 1 dose of vaccine. As you can see on the bottom right of the figure, this would avert projected 36% more death compared to a high risk strategy, prioritizing just the older part of the population. Similarly, the model was applied when you were projecting moderate to high transmission in the population. It's the same construct of the figure. When the optimal strategy in this setting here is always to vaccinate high-risk populations first, so older adults. Of course, whether you use 1 dose or 2 doses will depend on the single dose efficacy. 1 dose is sufficient, its coverage is low, but the single dose efficacy is high, and that would avert around 20% more death compared to pro-rata strategy, where you give it to everybody. Whereas 2 doses is needed, of course, if the single dose efficacy is low or moderate across all levels of coverage, as this would avert 41% more death compared to the pro-rata strategy. So in other words, the optimal strategy really depends mostly on the single dose efficacy, which is why this becomes a critical parameter to determine in trials as we move forward how much you can get out of single dose, as long as we still are short on vaccines. So this is a study that estimated the effect of mass testing for the need for social distancing and restriction. Again, it's something that has been contemplated. Can we actually handle a surge of transmission in a given population by doing mass testing of the population? So the current study investigated whether a one-time, two-week mass testing campaign with contact tracing of positive cases would result in reduced duration or restriction on non-essential, in-person activities in New York City in the winter of 2020. So it's based on a case here. It was a stochastic discrete time compartment modeling used in estimated SARS-CoV-2 transmission within communities and secondarily within households. And of course, the reproductive number was assumed to change over time based on policy and behavioral changes, as we would expect, and further calibrated based on observed mobility patterns and epidemic data from that particular city in question. Shutdown was triggered if the daily hospitalizations exceeded 2 per 100,000 residents in the population. Now, again, this is another complicated slide, but let me try to walk you through it. So this gives you on the top the number of new daily infections, and on the bottom the number of new daily hospitalizations, depending on the intensity of testing that population. And just of note, if you don't know it off the top of your head, in New York City, the population is 8.6 million. So you can see if you'd over a 2-week period administer mass testing in the range from either not doing it up to 56 million tests, you can see a gradual reduction in daily infections and daily hospitalizations. And really, if you then, on top of that, introduce contact tracing and quarantining, you can see that also affects how the shape of the epidemic or the surge actually behaves. Quite interestingly, you can see on the left and the middle row, the assumption is either to do 70% contact tracing or 90%, but only within 4 days, as opposed to only doing 50% contact tracing, but you do that very intensely just after patients were tested. And you can see that latter really was the most effective. So the combination of mass testing as well as very careful and very quick contact tracing was judged to be something that could actually almost curb and avoid any surge of hospital admissions. An important observation and really an argument for doing mass testing shortly in a short period to identify all remaining transmission chains in the population. I'll skip this slide in the interest of time. Another trial, another study, I should say, was addressing a different question, namely, what is men who have sex with men at high risk of COVID-19? What is it in terms of their sexual behavior if they have non-household partners, abbreviated NHPs, during an epidemic? And who is it that are actually at risk here? This is a study from the Netherlands. We know that some have sexual encounters with non-household partners, and they assessed the degree to which men who have sex with men reported reduced sexual encounters with partners outside of the house during the lockdown, and the factors associated with reporting high number of those contacts during lockdown. A little over 2,000 out of a total of 4,000 eligible men who have sex with men participants completed an online survey between July and September last year. And participants was self-reported sexual activity and COVID-19 related perceptions during 2 time periods was assessed, either during the pre-lockdown from January to February of last year, as opposed to during the lockdown from mid-March to mid-May. Overall, reported sexual activity decreased by 22% during the second time during lockdown, but 46% still reported sexual encounters with at least one non-household partner, increasing, of course, the risk of COVID-19 infection. During lockdown, 17 reported 2 to 4 and 9% more than 5 partners during that period. Factors associated with greater number of non-household partners was engagement in chemsex, loneliness, and people's perceived goals around having sex, whereas factors negatively associated with a greater number. So it was good compliance with COVID-19 rules and goals around protecting people's health. So you can see a really dichotomized way of thinking and addressing one's perceived risk of COVID-19 as opposed to one's perception of having sex. So findings really underscore the importance of targeted approaches to men who have sex with men to reduce the risk of COVID-19 transmission during sexual encounters. Two other studies I found to be very interesting. The first one was looking at the impact of COVID-19 lockdown on HIV care in South Africa. It was 65 primary care clinics that was examined that participate in the PEPFAR program. This was done in between January 2018 and July last year. And then as the different activities was happening in terms of the first wave of the pandemic was hitting the country, the segmented regression models was used to quantify the change before and after March 27 when that surge came. It's a fairly large study. I took note that they were assessing over 1.3 million HIV tests. 71,000 people had initiated ART during this period, and 2.3 million ART collection visits had been happening in those 65 clinics, and more than 340,000 missed collection visits was also observed during this. So this is a massive number of HIV care infrastructure that is being assessed here. As you can see, during the lockdown, as you can see in the first and in particular in the second quarter of 2020, there was a dramatic decline in HIV testing. It was reduced by more than 47%, but very quickly after the lockdown was reduced, was coming back, although not fully recuperating compared to the trends in HIV testing that was observed in the 2 years before that. Similarly, for people who had not started on ART already, you can see also here a dramatic reduction in the number of people who initiated ART during the most intense lockdown, and again some rebound after post-lockdown, but again not completely reverting back to the trends that were seen prior to the introduction of COVID. So a quite concerning interlink between a pandemic and how it disrupts the handling of this other pandemic in this high-hit part of the world. They also looked at ART collection visits for people who's already on treatment, and here you can see that although there was a slight variation, it was not dramatic and not something that could actually be observed to be of marked relevance. There was a little bit of an increase in missed ART collection visits just during the most intense lockdown, but recovering quite well. So the key message from this is that those who is infected may not get as frequently tested and may not start on ART treatment, at least in this program. And I think there is many data also from other places of high endemic HIV populations where HIV care has been significantly impacted by the COVID pandemic. Now, one thing that I thought was really interesting here as well is that many of the ART programs have been dosing and dispensing ART in fairly short intervals, so people had to come back to the clinic to get more medicine. That obviously allowed for also reintroducing adherence and compliance and so forth. But the question is whether that is really necessary. As you know, in many Western clinics, we are now extending visits to from now 6 months to most places 1 year. But many places in Africa and certainly also Eastern Europe at the moment, people need to come back to the clinic fairly quickly, fairly frequently. So this study was addressing this as there was a clear need to extend visit intervals. So we want to make sure that there is a uninterrupted provision of ART to people with HIV, while at the same time promote social distancing by decongesting health facilities. And that was obviously an impetus for why you want to explore multi-month dispensing as a factor here. So since March 2020, in this study, more than 30 of 50 countries with PEPFAR-supported ART programs scaled up their multi-month dispensing or expanded eligibility criteria to also include those that was previously ineligible, such as children, pregnant and breastfeeding women, persons newly initiated ART, and persons not meeting definition of clinical stable ART, those that you really is concerned about. But given the situation, that was done. This increased the capacity to supply chain for ARVs, provided focused support to sites and with previously low uptake of multi-drug dispensing for ART, established multi-month dispensing for persons at each facility, was adopted family-centered approaches to align household members, ART pickups, and involved community healthcare workers, patient navigators, and psychologists to support persons newly receiving multi-month dispensing for ART, and was coupling multi-month dispensing with community-based drug distribution. So a lot of efforts was made to ensure to the best ability that this was actually working well. The report here shows that there was some shift in this. You can see the proportion of people that was receiving a drug at least with a 6 months interval increased from 9% in March 2020 to 16%. On the other hand, the proportion who were coming back to the clinics with 3 months or later was reduced from 36% to 22%. So it's really important now to understand whether this was actually a sustainable strategy, as I believe that if this is eventually going to be documented to be a safe strategy, meaning that it doesn't affect compliance and adherence and eventually viral suppression, this will be a model that probably should be continued also after the pandemic is complete. That's yet to be determined. But if it is true, this can certainly be expanded to include TB prevention therapies, PrEP, chronic disease therapy, and other care models also in this section of the world. So something that we can learn from, learn because it was necessary, but maybe actually for the good also subsequent. So with that, I'll turn over to Jennifer, and if there's time for discussion, which I can see that there is 10 minutes, happy to take those questions. So Jennifer, over to you.
Yes, thank you, Dr. Lundgren, for that excellent presentation. We do have some time for questions, and we've had a number of them. So I'm going to mention briefly that several people requested these slides, and they will be available in approximately 1 to 2 weeks on the CCO website. So you'll be able to ponder these at home. Dr. Lundgren, we're having several questions about vaccine strategy. And so one question from a learner is, what is your opinion of the UK strategy to deliver a single vaccine dose to everyone before delivering a second dose?
So this is probably one of the most debated questions in the last couple of months, because different countries have come down on different sides of that question. Some have felt that the phase 3 trials was done using a certain interval, and therefore, in order to introduce those results into the public, we really needed to adhere to those, the way that this vaccine was studied, in order to ensure public confidence that the results from the trial could actually be expected to see in the population. On the other hand, as it was done in the UK, there was a policy decision to extend interval with 3 months, which was not necessarily that carefully studied, whether the single vaccine efficacy was sufficient to really maintain good protection for the individual. The benefit of that strategy was obviously that more people could get vaccinated. I think it's still open for discussion which of those two strategies is the correct one. My personal preference is at the moment to follow the science. The science shows how we should dose the vaccines and what we should expect in terms of vaccine efficacy. And since this has been going so quickly, I think it's maybe a little bit premature to start to experiment right away. Although I appreciate the legitimate argument that if by spreading doses apart, you can get more people vaccinated. Eventually, this is going to be shown not only in terms of public confidence, but also something that I think we all are focused on at the moment, namely escape variants, so variants of the virus that is able to replicate and overcome the immune protection. And we know that the immune protection is less robust after just one shot, as opposed to the second shot. There's a lot of data on that it is the second shot of the vaccine that really gives the boost to the neutralizing antibody titers in the body. And whether there is some issue in terms of delaying that second shot and therefore allow for more people in the population to evolve, allow the virus to evolve into escape mutant. It's obviously too early to say, but I appreciate the points and the discussion on both sides. But personally, I would go with the science.
Yes, that was wonderful, Dr. Lundgren, and you answered several questions there because we had a question from Ulrich about variants and the single-dose efficacy. But another question we've had from John is, can you discuss any theoretical basis for assuming that single-dose efficacy will be different based on mechanism of the vaccines? So between viral vector vaccines versus mRNA vaccines?
Well, we haven't seen the results from the J&J vaccine yet, but that is a single-shot vaccine, which is at least reportedly having a quite high efficacy. So there is different ways that you can stimulate the immune system to develop a robust and protective, a clinically relevant protective immune protection of the individuals. I think it's really too early whether... and we really need to explore, in particular, the mRNA vaccines, what happens to the efficacy if you extend the duration in between the first and the second shot beyond this, 3 to 6 weeks, which is sort of the usual, what I think, all feel comfortable around if you want to, quote unquote, follow the science. If we really significantly extend the second shot, what happens? There's very little data to inform that. On the other hand, the AstraZeneca vaccine, there was just a paper coming out today and just also the other day on the first results and experiences in the UK using this strategy. And at least according to those papers, it looked reasonable. But I think it's still an open debate and something that I think we'll ponder on for several months hereafter.
Right. We have another question here about how long it might take to get these single-dose efficacy studies, given that we have such a mixed pattern of vaccination strategy across the world. And as a corollary to that, somebody is wondering if it's even necessary, given that we have such good vaccine efficacy with the emerging vaccines. Do we need the head-to-head trials at all? And about the single-dose efficacy vaccines, won't it take really long time to get those done?
No, I appreciate those questions. We can debate, do we actually need more research now, or should we just go ahead and do mass vaccination? And I appreciate that point. But on maybe a second note, I would argue that we're not done with doing research because the vaccines are introduced into the general population. There's multiple questions that we don't know the answer to, and where phase 4 trials are really critical to inform those questions, including what is the duration of the vaccine effect on the individuals. and which factors actually play a role in the duration of the vaccine efficacy, as one example. And in terms of the head-to-head vaccine trials, well, if we believe that the vaccines that we now have, the 4, maybe 5, maybe 6 vaccines, that is sort of what I would characterize as the first generation vaccines, if we believe that's sufficient and we don't need any more, then of course you can debate, well, do I really need to know whether the vaccine efficacy is equivalent between two of them, or should we just go along and vaccinate a lot of people and then let's get over with it? I don't really personally see it this way, because I think we will be forced to continue to remind the immune system about its immunological function against this virus. And I would be stunned if none of the sort of second or potentially even third generation vaccines would not be the ones that we eventually is going to use for that further reboosting. And so, but of course, in order to do that, we would also need to do head-to-head comparisons, because we want to know whether those new vaccines, and again, I mentioned there's over 200 vaccines in various stages of development. We want to make sure we understand whether they are actually equivalent in their efficacy and not, of course, exceeding with harm compared to the vaccines that they would potentially replace. So I think we have seen that in many other medicines area, and I will bet you we're going to see it here. And I don't know about you, but I have to say everybody is focusing on the vaccine efficacy of 76% or 94%, and some is actually 94.5%, like this is sort of a magic number. But we all know that's not true, right? And we need to be very careful in comparing vaccine efficacy results from one trial to vaccine efficacy results from a other trial, because that inter-trial comparison may not be valid, because the populations in the two may not look like each other. So another argument for head-to-head trials. I think that will happen.
Okay, great. We have another question from Sharon about mass testing. And given what you know about mass testing and viral shedding and so forth, what do you recommend, and what is happening in your country?
I have to say that we need to be, I mean, the strategy, I think, not only my country, but I think many countries now, is that we need to rely on rapid testing, preferably home testing, and do it frequently and make it very accessible. That has worked for HIV. That has worked for other infectious disease. The technology is emerging, and it's going to be a cornerstone in handling the pandemic. And then, of course, the vaccines. It's going to be the two parameters technologically that we need to focus on, while still also encourage people to change their behavior, right? The physical distancing and then the contact tracing that I also showed on the slide. Those things is going to be those four things is going to be critical in handling this. I'm afraid we're not done with the SARS-CoV-2 this summer, despite the fact that we may have vaccinated a lot of the population.
Yes. Well, many thanks to you, Dr. Lundgren, for that excellent program, and it's unfortunate that we're out of time. Thank you again, Dr. Lundgren, and thanks to our listeners for joining in. As a reminder, to view the full conference coverage program of the IAS COVID-19 Conference Prevention on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.